So we are live now. Good evening and a very warm welcome to all the doctors who have joined today's webinar. I am Neetu Abraham, Community Manager at Medisage eLearning. At Medisage, we empower doctors with the right blend of knowledge and technology to enhance clinical practice and patient outcomes. With AI transforming healthcare, we have introduced Sage AI, a medical grade AI built exclusively for doctors. This entire webinar is co-powered by Sage AI and now it is freely available on Medisage app, offering reliable evidence-based support anytime and anywhere. Now it is my pleasure to introduce our esteemed faculty for today's session, Dr. Ankur Kumar Patel. Dr. Patel is an assistant professor in the Department of Pediatrics at Government Medical College Surat with over 14 years of teaching experience. He completed his MBBS and MD in pediatrics from the same prestigious institution and has been actively involved in teaching, clinical practice, and research throughout his career. He has authored several research publications in reputed medical journals with key contributions in areas such as measles, severe pneumonia, HIV, thalassemia, and other important pediatric conditions. His passion for evidence based medicine and medical education has made him a respected academician and speaker. We truly honored to have him with us today to share his expertise on the topic hidden endocrine problem in thalassemia major. So we welcome you, sir, on our platform once again, and let our viewers know that what they are going to learn from today's webinar regarding our topic, sir.
Sincere gratitude to Message for hosting today session and enabling the seamless knowledge sharing across the medical community. So today let's keep improving the clinical outcomes for children battling with the thalassemia major. So today webinar early detect diagnosis and treatment for hidden facts related to endocrine problem in thalassemia major in children.
Hmm. Okay, sir. So, without any delay, let's move on to our first question for the topic. To start with, when we think of thalassemia major, endocrine issues often take a backseat. Why do you think these complications are still under recognized in routine practice?
So endocrine complications are often insidious. In a busy clinical setting, the focus of heavily skewed toward the regular blood transfusion management, control of the infection, chelation adherence, and cardiac health issue related in thalassemia major in children. So never focus on endocrine problem. And endocrine symptoms usually comes with fatigue, subtle growth deceleration, overlap with the underlying anemia or chronic disease burden. So clinician or pediatrician often attribute this finding to the baseline thalassemia rather than screening for specific endocrine gland related issues. So endocrine dysfunction, especially pituitary gland or any other gland, develops gradually because more than 10 to 20 PEG cell volume transfusion usually affect the first linear or liver organ due to parenchymal iron deposition. So after age of 2 to 3 years of diagnosis, when serum ferritin levels exceeds more than 1000 nanogram per ml, that's why iron starts accumulating in the organ such as liver, followed by heart and rest of the any other endocrine glands. But why 1 units of transfusion affect the serum ferritin level high? So we have to learn that 1 unit of PEG cell RBC or PEG cell volume adds 200 to 250 milligrams of iron. So after 10 to 20 PCV transfusion after 1 to 2 years of diagnosis, iron burden exceeds the physiological clearance capacity. So organ affect first are liver because of hepatic parenchyma affects first, followed by endocrine glands and myocardium. So we have to focus first related to transfusion after 10 to 20 blood transfusion. So, endocrine complication remains occurred in many centers due to lack of routine screening protocols or due to lack an integrated multidisciplinary team approach. Other and then the endocrine glands are particularly susceptible to iron-induced oxidative injury because they have limited antioxidant defenses. That's why we have to focus more on endocrine problems rather than routine thalassemia major treatment in the children.
Hmm. Okay, sir. Okay. So, the next question is from your experience, which endocrine disorder is usually the first to show up in these patients, and what are the earlier clues that clinicians tend to miss?
Growth failure is usually the earliest endocrine manifestation. So we have to somatotropes, which is growth hormone, which is secreted from the antipituitary, and gonadotropes, luteinizing hormone or follicle stimulating hormone, also released from the anterior pituitary hormone. So are particularly vulnerable to iron deposition. So hypogonadism is the single most common endocrine disorders in the thalassemia major. So 40 to 80% of patients, depending on the efficacy of the chelation therapy during the late childhood, patient may come with hypogonadotropic hypogonadism. So early missed clinical cues in the form of falling height percentile, deceleration of the growth velocity is a subtle loss of normal pubertal linear growth height percentile between the age of 9 to 11 years of age, which causes visible pubertal growth arrest. Second will be poor weight gain, which is also early missed clinical clues. Delayed born age, fatigue, even after remain persistent, adequate blood transfusions, poor academic performance, reduced exercise intolerance, absence of pubertal testicular enlargement in the boys in less than volume of less than 4 ml in boys by age of 14 years. In girls, if absence of tenor stage B2 in age of less than 15 years, loss of pubertal growth spurt are the early missed clinical clues. So in conclude, we have to analyze by annual height velocity is much more informative than the single height measurement. So we have to regular follow-up growth chart assessment by assessing the growth velocity of the boys and girls. Second will be children grows with the growth velocity deserves in males and females, boys and girls, in a form of less than 4 ml per volume in age of 14 in boys, and less your TNM stage according to B2. Absence of breast bud development in less than 15 years of is a worrisome sign. We have to look for the growth failure in the children.
Okay, sir. As you rightly said, growth failure is something we frequently see. How do you differentiate between nutritional cases, chronic disease, and a genuine endocrine problem in a child with thalassemia? You have partly answered this. More descriptive, sir.
So growth failure in thalassemia is usually multifactorial, stemming on the from the chronic hypoxia, iron toxicity, chelation side effects, and specific endocrinopathy. So we have to analyze by symptoms individually. So chronic anemia and hypoxia, primary mechanism in which chronic tissue hypoxia, which causing by inadequate blood transfusion, which causing massive marrow expansion, in which key clinical features are hepatosplenomegaly or thalassemic phases, in which we have to laboratory finding or radiological finding in a form of maybe patient maybe come with HB between hemoglobin between 6 to 8. We have to require adequate regular blood transfusion, which growth pattern will be steady deceleration, but head height proportion will be normal. In case of nutritional failure or deficiency, primary mechanism is trace element deficiency in a form of zinc deficiency, protein and calorie malnutrition, or maybe micronutrient deficiency is a primary mechanism in which key clinical features are low weight for age, low height for age, maybe come with severe acute malnutrition, or maybe subcutaneous loss of subcutaneous fat, or maybe muscle wasting. In which laboratory finding or investigation we have to require in a form low serum zinc level, low vitamin D level, hypoalbuminemia, low albumin level. Maybe patient may come with loss of subcutaneous fat. In growth pattern, we have to analyze by or assess by triceps skin fold thickness, or maybe because of high dose of deferricerox. Growth pattern will be spinal dysplasia or maybe short tongue deformity. Lastly, true endocrine dysfunction is maybe due to growth hormone or maybe IGF-1 deficiency, in which primary mechanism will be anterior pituitary, which cannot release the growth hormone, or maybe LH or FSH. Luteinizing hormone or follicle stimulating hormone cannot be released by anterior pituitary hormone. So in which key clinical features are progressive height deceleration, or maybe child come with short stature, or maybe delayed puberty, or maybe pubertal growth arrest, in which investigation by bone age assessment, maybe assessment by LH or FSH hormone level, or maybe growth hormone level. So in which growth pattern will be severe reduced height velocity by less than 4 centimeter per year in adolescent age group.
Okay, okay, sir. So, coming to your experience, sir, you have worked on hypothyroidism in thalassemia. So, how common is it in your practice, and how should we be screening even asymptomatic patients?
So primary hypothyroidism occur in 10 to 30% of patients with thalassemia major in children. So dominant presentation is subclinical primary hypothyroidism, in which elevated TSH level, thyroid stimulating hormone with normal free T4 level, due to direct anterior pituitary and thyroid follicular cell iron toxicity. Otherwise, central hypothyroidism secondary cause, in which low or normal TSH level with low free T4 level occurs due to severe pituitary damage. So in primary hypothyroidism is because of elevated TSH with normal free T4. In case of central hypothyroidism, which low TSH or normal TSH with low free T4 due to pituitary damage. So thyroid follicular cells directly internalize the circulatory iron, triggering the chronic localized oxidative inflammation. So in which we have to universal mandatory for annual screening for all thalassemia major patient starting at the age of 5 years of age, even if completely asymptomatic. So we usually analyze after assessing the short stature or maybe height velocity is not achieving the adolescent age group, but we have to assess the hypothyroidism in 5 years of age, even though child is asymptomatic. Why rationally for asymptomatic screening? Because asymptomatic subclinical hypothyroidism accelerates the cardiac dysfunction, which causing increased systemic vascular resistance, which causing fatigue. Maybe patient may become restlessness. So early stage of subclinical hypothyroidism induced by iron toxicity can sometimes maybe reverse or stabilize through the intensive iron chelation therapy. So early levothyroxine therapy in case of primary or secondary hypothyroidism, replacement in subclinical hypothyroid state in thalassemia major patients significantly improves cardiac and metabolic parameters and restores the normal linear growth of velocity. So we have to early diagnose, early treatment for hypothyroidism after the age of 5 years of age completed.
Okay, so you're saying that from the age of five, as soon as a
5 years
child turns
completed.
5 year old, you have to test them for hypothyroidism.
Yes. Even the
Okay.
primary or secondary.
Okay, okay, sir. Okay. So the next question is, when it comes to thyroid assessment, are there any common pitfalls in interpreting thyroid function tests in chronically transfused children?
So, evaluating thyroid axis status in chronically transfused children presents with the sick euthyroid syndrome in a form of non-thyroid illness, central hypothyroidism, or maybe underestimating the some clinical hypothyroidism. So, we first discuss the sick euthyroid syndrome, non-thyroid illness. It usually occur in acute systemic stress, chronic severe anemia, or severe hepatic iron overload. Reduce the peripheral conversion of T4 to T3, which causing low free T3 level, normal TSH level, or variable T4. So in this child, treating this state with the levothyroxine is unnecessary and harmful because endocrine gland is not affected because of acute systemic stress, chronic anemia, and severe hepatic iron overload. Maybe laboratory जो parameter maybe differ in maybe falsely positive occur in sick euthyroid syndrome. In central hypothyroidism masked by the mild TSH elevation, iron damages to the pituitary can cause secretory defective TSH molecules or blunted nocturnal TSH surges. So a normal or mildly elevated TSH can coexist with the pathologically low pre-T4. So we have to central hypothyroidism, we have to wait and watch for after 3 months analyzing the free T3, T4, and TSH level, then we decide whether child is required for thyroid treatment or not. Underestimating the subclinical hypothyroidism, isolated elevated TSH hormone with normal free T4 should prompt dynamic evolution because in repeating FTF4, 3T4, TSH after 3 months, evaluating the cardiac T2 MRI rather than the immediate high dose of replacement, as mild TSH elevation can sometimes transiently normalize after intensified chelation therapy. So we have to first focus on the iron chelation therapy rather than the assessment of the hypothyroidism. So after 3 months of intensified iron chelation therapy, we have to work for the pre-T3, pre-T4 and TSH level rather than we initially recording the reports and we initially start the thyroid treatment which cannot be harmful, which can be harmful or cannot be effective also.
Okay, sir. So we, you have already stated about delayed puberty. It is an concern in this case. So at what point should pediatricians start evaluating these children instead of simply waiting a little longer?
So a wait and see approach in thalassemia major frequently leads to permanent epiphyseal fusion without achieving the adult height potential, alongside with severe psychological distress and unmanaged bone mineral density loss. So evolution in cutoff from girls and boys. So in case of girls, absence of breast bud development or no breast buds in stage of B2 tenor stage by age of completing 13 years age. Second, in primary amenorrhea by 15 years of girls is a warning sign for delayed puberty in thalassemia major children. In case of boys, absence of testicular enlargement or testicular volume less than 4 ml by 14 years of age completed in boys, or delayed scrotal pigmentation by age of 14 years in boys. In pubertal arrest, lack of tenor stage progression over a 12-month or 1 year period of any age is considered to be a pubertal arrest. So in case of any child come with delayed puberty, diagnostic protocol for evaluation by basal hormonal level, morning serum luteinizing hormone or follicle stimulating hormone or testosterone in case of males. In case of female, it by LH and FSH level. So in case of low luteinizing hormone or follicular stimulating hormone levels confirms the diagnosis of hypogonadotropic hypogonadism. In case of males, low testosterone is confirms the hypogonadotropic hypogonadism. JNRH or LHRH stimulation test, why it is required? It is required to distinguish between the early constitutional delay from the permanent pituitary gonadal tropin hormonal damage. Last will be your bone and edge assessment by radiograph of the left hand or wrist, and maybe non-invasive method by DEXA scan, which also diagnosed by dysplasia, or maybe bone marrow maybe not functioning, or maybe bone maybe not showing the pubertal arrest level. And last will be your non-invasive but little most costlier pituitary MRI T2, which quantifies the pituitary iron overload in the brain and also in the other organ like heart, cardiac, maybe pancreas, and other pituitary gland.
Okay, sir. Like you rightly stated about hypogonadism that can have huge impact in long-term quality of life. What practical approach do you follow for diagnosis and timely intervention of this?
So management involves early identification and initial window for intensive chelation to attempt the reversal and structured bio-identical hormonal replacement therapy to induce the puberty safely. So if diagnosed early, intensive iron chelation therapy can lower the pituitary iron and occasionally restore the spontaneous gonadotropin secretion. Once the hypogonadic hypogonadism when confirmed, so intensive chelation therapy should be started. Duration of therapy will be 6 to 12 months. In case of females, if age of completed 12 to 13 years, low dose estrogen therapy, which is gradually titration over the 2 to 3 years, which causing add cyclic progesterone hormone, which induction of the fertility will be safer. In case of males, age of 13 years or 14 years completed, low dose testosterone titrate by the every 6 to 12 months, which causing full adult replacement therapy can be achieved. So we can prevent the hypogonadism in the adolescent boys and girls.
Okay, sir. So we have discussed a lot about thyroid and gonads. Apart from this, what other endocrine glands should clinicians actively monitor in thalassemia major?
So beyond the thyroid and gonads, iron overload damage the other major endocrine or metabolic issues. So first will be your parathyroid glands. In parathyroid glands, child usually come with hypoparathyroidism. In 10 to 20% of patient, child come with thalassemia major having hypoparathyroidism. Why it is occur? Because parathyroid tissue is highly sensitive to iron toxicity and ischemia. Usually, hypoparathyroidism clinical manifestation in a form of paresthesia, muscle cramps. Sometimes child come with positive Trozius signs, prolonged QTC interval in ECG findings. Sometimes child come with seizures. So how will you monitor this child? So monitoring of this child by annual serum total calcium, ionized calcium, serum phosphate level, intake parathyroid hormone level, vitamin D level should be monitoring or starting after the age of completed of 10 years.
Mhm.
Second endocrine problem will be diabetes mellitus. Usually diabetes mellitus occur in 10 to 25% of children. Why it is occur? Because of dual insult, direct pancreatic B cells iron accumulation leading to impaired insulin secretion combined with the hepatic iron deposition causing severe systemic insulin resistance. So how will you monitor this child? By not analyzing by the normal glucose level or HbA1c level, we have to confirm the diabetes mellitus in thalassemia major by annual 2-hour oral glucose tolerance test starting at the age of completion of 10 years.
Mhm.
Because fasting blood glucose and HbA1c are unreliable in thalassemia due to shortened red cell lifespan and high erythrocyte turnover may be falsely elevated your blood glucose level in thalassemia major in children. Third endocrine problem will be adrenal cortex, which present may be child come with primary or central adrenal insufficiency, in which 15 to 30% children come with subclinical prevalence. Why it is occur? Because iron deposition occur in adrenal cortex of zonal fasciculata and reticulosa of adrenal glands, or maybe anterior pituitary corticotrophs hormone affected which causing maybe adrenal insufficiency. So this child may be monitored with annual monitoring of the cortisol starting at the age of 12 years, critical during the physical stress, physiological stress, systemic infection or surgery to prevent the acute adrenal crisis. So maybe falsely report may be positive occur. So we have to rule out the stress condition, infection and surgery before the diagnosis of the adrenal insufficiency.
Hmm. Okay, as you rightly mentioned, just overload is usually blamed for endocrine dysfunction. Is ferritin alone enough to estimate the risk, or should we be looking beyond ferritin?
So serum ferritin alone is insufficient to predict the endocrine risk. Relying solely on the ferritin creates significantly diagnostic blind spots. Why limitation of the serum ferritin investigation? Because in acute phase reactant, ferritin rises significantly during the inflammation, hepatic dysfunction, or infection, falsely overestimating the iron burden. Poor correlation with the specific organ iron, pituitary, pancreatic, and cardiac tissue sequester iron via specific labile plasma iron uptake pathway at different rates rather than liver and reticuloendothelial system. So patient may be maintain acceptable ferritin level less than 1000 nanogram per ml while silently suffering heavy pituitary or cardiac iron loading toxicity. So we have to analyze by serum ferritin not, but advanced risk stratification modality in a form of T2 magnetic resonance imaging by hepatic MRI is a gold standard for total body iron burden, which detect the liver iron concentration. In case of cardiac MRI T2, in which T2 less than 20 millisecond indicates cardiac iron overload, in T2 MRI cardiac less than 10 millisecond represents the high risk for severe heart failure or severe multi-gland endocrinopathy. In case of pituitary and pancreatic T2 MRI directly measures the organ-specific iron deposition, allowing early chelation adjustment before the irreversible glandular fibrosis occurs. So better than MRI is a best investigation rather than serum ferritin. Serum ferritin you have to assess by every 3 month assessment whether ferritin level is ups or down. But silently less than 1000 nanogram per ml, we have to assess by T2 MRI in a form of pituitary, hepatic, cardiac, pancreatic, other endocrine gland. So it is important to not rely on only serum ferritin investigation.
Okay. So, looking ahead, are there any emerging therapies or advances that you believe could reduce endocrine complications in thalassemia major patients, sir?
So modern management strategy aims to transform the endocrine prognosis of the thalassemia major. So first will be your erythroid maturation agent in a form of luspatercept. So luspatercept enhance the late stage erythropoiesis by neutralizing the beta ligands, restoring the late stage erythroblast maturation, reducing the ineffective erythropoiesis. So these drugs significantly lower the transfusion burden by 33%. So in complete transfusion independence in a subset of a non-transfusion dependent thalassemia. So these drugs decrease the transfusion burden in 33%, directly decreasing the systemic iron accumulation of the toxic labile plasma iron in endocrine organ. So it is effective drug. It's a erythroid maturation agents. Second will be your curative gene therapy and gene editing. So ex vivo gene addition reactivates the reactivates the fetal hemoglobin, inserts the functional beta globin genes, achieving transfusion independence stops exogenous iron loading entirely coupled with the forced transplant chelation. This can deplete the existing tissue iron stores and prevent the further endocrine deterioration. So ex vivo gene addition is also effective to reduce the transfusion load in the thalassemia major in children. Last will be your targeted intracellular oral combination of the chelation therapy. Utilizing the dual chelation protocols, specifically combining deferepron, it's a small lipophilic molecule that crosses the cell membrane and extracts the intracellular iron. With desferrioxam or deferresirox, actively removal iron from the cardiac and pituitary tissue, helping the reverse early stage of subclinical endocrinopathy. So in a form of three treatment, first will be your erythroid maturation agent, second will be your ex vivo gene addition therapy, and third will be your targeted intracellular and combination of chelation therapy is effective for modern treatment for thalassemia major. But lastly, curative therapy or permanent cure by hematopoietic stem cell transplantation, but it is very costlier
Hmm.
treatment.
Okay. So these therapies are currently in use or they are just emerging, sir? How is it?
Deferresirox is usually available, but new emerging therapies, erythroid maturation agents, and ex vivo gene addition therapy.
Mm-hmm. Okay, okay, sir. So last but not the least, if every pediatrician listening today remembers just three clinical pearls about endocrine care in thalassemia major, what would they be, sir?
So Pearl will be serum ferritin does not protect the pituitary, cardiac, or pancreatic organ. You have to use organ-specific MRI surveillance at the completion of age of 8 to 10 years because a normal or modestly elevated ferritin level does not rule out severe pituitary or cardiac iron loading. So utilize the cardiac, liver, pituitary, or pancreatic T2 MRI starting by the age of 8 to 10 years to tailor the chelation before the irreversible organ damage occurs. Pearl
Mm.
2. Never use HbA1c or fasting glucose alone for the screen for the diabetes in thalassemia major children. Usually perform the annual oral glucose tolerance test after the age of completion of 10 years. Due to high red cell turnover and chronic hemolysis, HbA1c consistently underestimates the glycemic status in thalassemia major patient. So annual two or oral glucose tolerance test starting by the age of 10 years is essential to detect the impaired glucose tolerance early while beta cell function can still be preserved. Pearl 3, track the linear growth velocity and Tanner staging at the every visit. So early intervention preserve the fertility and height in adolescents, boys and girls. So growth failure and hypogonadotropic hypogonadism are insidious. A drop in high velocity below the 4 to 5 centimeter per year in prepubertal children or lack of testicular growth less than 4 ml in boys completed of age of 14 years. In case of girls, no breast bud development birds in tenor stage B2 after the girl in age of completion of 13 years requires immediate endocrine evaluation and chelation therapy intensification associated with every follow-up. We have to monitor by growth chart for assessment of the boys and girls in the children for prevention of thalassemia major complication related to endocrine issues.
Uh, okay, sir, you got muted? No,
Yeah.
right. Yes, sir. So, with this, we have answered all the questions, sir, for this podcast. We have some viewers' question. So the first question is, can a normal ferritin still hide significant endocrine complications?
Yes, it can be possible because we already mentioned that less than 1000 ferritin level can affect the damage to the basically it is a tip of iceberg phenomena. Maybe child come with regular blood transfusion after 10 to 20 is highly vulnerable to iron toxicity in the major organ like liver, maybe in pancreas, in maybe in the endocrine gland of thyroid gland. So we have to watch full after the completion of 2 years of PEG cell volume transfusion, regular transfusion. We have to watch for this iron toxicity in every organ. And after 5 years of age, we have to assess the endocrine problems also.
Okay, sir. So the next question you might have already answered this, sir. For delayed puberty, when it is time to stop waiting and start investigating?
So usually mention that we have to, after the age of completion of 10 years, we assess by the growth chart. Growth chart assessment, serial follow up the growth chart. We have to assess the growth velocity of the curve. If less than 4 to 5 centimeter per year, or maybe not completing by the tenor stage of assessment of the child in boys and girls, we have to look for delayed puberty and we assess by assessment of the hormonal status after the age of completion of 10 years. So we usually assess by usually adolescent age group is between the 10 to 14 years. So we have to look for the assessment of the adolescent boys and girls by assessment of the growth chart and assessment of the hormonal status. We can diagnose early delayed puberty.
Okay. Next question is, can a child have normal growth today but still be at high endocrine risk later?
Yes, it can be possible. After 20 to 30 transfusion, every child is vulnerable to develop complication iron toxicity due to maybe combined iron chelation therapy likely to be developed complication in the endocrine issue related to iron overload, related to growth failure, maybe occur after 3 to 4 years of regular blood transfusion of can occur any complication in a form of endocrine, in a form of iron toxicity, in a form of pituitary gland. It can be developed diabetes in futures also.
Okay. So one more question. Can endocrine complications affect quality of life even before they become clinically obvious?
Yes, if child develop endocrine problems, child may
Hmm.
be develop secondary bacterial infection in form of if patient diagnosed diabetes mellitus, this child is already immunocompromised state and develop diabetes mellitus or maybe growth failure. It's required lifelong therapy in a form of growth hormone injection until the maturation achieve in a form of epiphysis fusion. So this child is required highly cost effective therapy in a form of growth hormone injection. Diabetes mellitus patient may be required uh, treatment of insulin injection sometimes may be required or maybe some required medication of the treatment related to diabetes mellitus. Sometimes maybe child may be having develop hypoparathyroidism, which also require biphosphate treatment to related to decreased parathyroid hormone level. So every organ affect major organ affection, which can be causing every infection, maybe related issue, maybe related to hormonal therapy, related to endocrine treatments required mostly occur in every thalassemia major children, because 10 to 30% prevalence occur every endocrine organ problem. So it may be affect with diabetes, it can be affect with parathyroid hormone, it can be affect unilateral in maybe combined with diabetes, can be combined with parathyroid hormone. In fact, hypoparathyroidism, maybe diabetes can be associated with the growth or failure growth hormone therapy. So it can be maybe single child come with diabetes also, or maybe child come with growth failure also combined.
Hmm.
Okay, so we have to focus every endocrine system in this child thalassemia major.
Hmm. Rightly said, sir. So, with this, you have answered all our viewers' question. We sincerely thank you, Dr. Ankur Patel, for this insightful session. We truly appreciate your time, effort, and contribution towards this webinar, sir, and engaging our viewers and enhancing their knowledge as well on this topic. We look forward to hosting more such enriching sessions with you. To all our viewers, thank you for being interactive and for participating in today's discussion. For those who missed this session, it will soon be available in the past events section of MediSage app. Be sure to check it out. Any last concluding remarks from your end, sir?
Thank you, Medisage, for wonderful platform, and special thanks to every attendee for the insightful questions. And together we keep improving clinical outcomes for future children's battling for thalassemia major in children.
Yeah, definitely, sir. Thank you for joining us today.
Thank you.